Olá a todos, então bem-vindos a mais um podcast. Desta vez vamos estar à conversa com Pietro Bini. Vamos falar sobre a eficácia de terapia manual e exercício terapêutico em pacientes com cefaleia cervicogénica. O Pietro Bini é o primeiro autor neste paper de 2022 e vamos discutir aqui então um pouco esta revisão sistemática e meta-análise recente na cefaleia cervicogénica. O Pietro Bini é fisioterapeuta, tem um Master em osteopatia pela UCO e a University College of Osteopathy e é, como eu disse, o primeiro autor deste paper, que tem o nome de Effectiveness of Manual and Exercise Therapy on Headache Intensity and Frequency Among Patients with Cervicogenic Headache, a Systematic Review and a Meta-Analysis. E agora vou começar a falar então em inglês para entrevistar aqui o Pietro. Pietro, thank you so much for coming and for being available for this talk. And congratulations for this paper. I read it a few times. It's a systematic review and meta-analysis, a recent one, 2022. Yeah, I have a special interest in this kind of material, and I just introduced you, and my kickstart question would be for the ones who are not so familiar with this type of headache. What is this cervicogenic headache? I mean, the name kind of says it all quote unquote. I mean, it's a headache coming from the cervical spine, we think, but what is this? What are the diagnostic criteria? What exactly is the cervicogenic headache? What do we know about it? Can you just introduce the theme, the subject from that?
Thank you, Bruno, for the introduction, first of all, and thanks everyone for listening. Yes. So, cervicogenic headache, as you said, the name itself says it all. So it's described as a secondary type of headache in contrast to other primary headache forms like migraines, tension type headache, or cluster headache. And this means that a secondary headache, such as cervicogenic headache, comes as a consequence of a structural damage or a pathology that we know that can lead to for a person to experience headache. In this specific case, we're talking about any type of irritation, any type of damage within the upper cervical spine. So any structures really that are supplied by the first three spinal nerves. Any of these structures that can be an articular structure, a capsule, ligaments, a muscle, bone itself, then they can refer pain to the head. This is due to the fact that the first three spinal nerves converge within the spinal cord and the brainstem. They converge with the pars caudalis of the trigeminocervical nucleus, which then converges with the trigeminal nerve. So basically, there can be an afference coming from the upper cervical spine, can converge, the pain signal can then converge within the trigeminocervical nucleus with the trigeminal nerve, and it can then be referred to the area that is supplied, the facial area that is supplied by the V1 branch of the trigeminal nerve.
Very good, and it's important to refer that it's solely the ophthalmic branch of the V1, because that's the really one that goes to the pars caudalis. Yep.
Because the trigeminocervical nucleus is divided in three parts. The more caudal part is the pars caudalis, is the one that actually has afferences and an overlap with the first three spinal nerves, whilst the pars oralis and interpolaris, which are higher up within the trigeminocervical nucleus, which then lead to the V2 and V3 branches of the trigeminal nerve, do not, in fact, have an overlap with the first three spinal nerves. So generally, the pain is always described going from the occiput, which is usually also the source of the actual source of pain, and then it goes towards the orbital region, but it never really reaches the mandible or the face itself. It just stays within the frontal, temporal, and orbital region.
It's kind of typical. They say this. They describe this. Yeah.
And it's important to describe that the patient kind of describes that coming from the occiput towards the orbital region, Also for differential diagnosis, because migraine, for example, with and without aura, can usually be described as with a similar spatial distribution, but with a different type of radiation, if you want. So it can radiate from the orbital region towards the occiput. And this is pretty important as we listen to patients and they describe the symptoms. It's important to listen to this detail because it could lead you to think of a diagnosis rather than another.
Yeah, and it would kind of leads us to the diagnostic criteria, because as you said, there's so many sometimes similarities or resembles of in this different type of headaches, and we know the trigeminal nerve plays a key role in this inflammation and in all sorts of headaches. You know, the trigeminal, for the ones who don't know, also the trigeminal nerve or the trigeminal tracts, the dorsal and ventral trigeminal tracts are responsible for also perceiving pain coming from the face and coming from the upper cervical spine. So there's a role of the trigeminal nerve with this inflammation and in the post-inflammation phase, anti-inflammation phase, kind of modulates, regulates, also activates the inflammatory in this type of migraines, not just the cervicogenic headache, and kind of leads us to the second part of the question, which is, do we know of what are the diagnostic criteria? There's a few that are important for establishing kind of a cervicogenic headache coming from the cervical spine. Can you talk a bit? Yeah.
Absolutely. And there's also some debate regarding the official, if we want, diagnostic criteria at the moment. I mean, actually, in the last 15 to 20 years, there's been debate. So the most regarded diagnostic criteria are the ones described by the International Headache Society. The latest version of the ICHD, the International Classification of Headache Disorder, which is the third version published in 2018. Gives the set of criteria that is most commonly used at the moment, and basically they do underline the fact that there must be a temporal an evidence of temporal causation between neck symptoms and headache symptoms, but as far as other headache study groups, in particular the Cervicogenic Headache International Study Group, as far as they're concerned, some of the features described by the International Headache Society are not enough to actually safely diagnose cervicogenic headache. So the main feature, so let's say that at least when I'm in my clinical practice, when I see a patient with cervicogenic headache, which I actually see a lot of at the moment, I try to take into account both classifications to have a better idea of where to, let's say, where to consider, what type of diagnosis to consider for this patient. So things that, for example, the Cervicogenic Headache International Study Group considers fundamental are the side lock pain, the fact that there is a certain amount of range of motion restriction, which instead are not part of the diagnostic criteria as far as the International Study Group, International Headache Society, are concerned. And these are really important features because the side lock pain, the fact that the pain is pretty much always on the same side for the patient, is really important and is something that has always been described as part of these symptoms, and it can help to differentiate between, among other headaches. As well as the fact that instead for the International Headache Society diagnostic criteria, they focus, the diagnostic criteria are very much focused on the fact that the headache can worsen together with the neck pain symptoms, the headache can improve together with the neck pain symptoms, and there is also a temporal relation. So they manifested themselves for the first time pretty much at the same time, or with not as much of a time difference between the two. But at the same time, for example, the improvements of the symptoms of the headache together with the neck pain symptoms for a patient that just started developing cervicogenic headache can also not be that important in the diagnostic criteria, because the patient might not have had an improvement in the symptoms yet. So that's, for example, one of the criteria that the Cervicogenic Headache International Study Group kind of debate that have been included in the more official diagnostic criteria. At the same time, one of the main differences is that as far as the International Headache Society, so the more official criteria are concerned, a diagnostic blockade is not necessary. And the International Headache Study Group does agree with that to a certain extent, because they instead recommend for diagnostic blockades to be compulsory for scientific purposes, so at least for scientific articles, so that we are absolutely certain that the type of patient population that has been studied, that has been recruited within a study, was diagnosed with the correct headache. As again, it can be very the phenotypic manifestation can be very similar to other types of headache.
Yeah, we see it very clearly in clinical practice. It's this so important. No, this, I feel like I should underline that, because this kind of unilateral symptoms. If we're talking about some damage or some degeneration or some previous damage on the cervical spine on one side, that then triggers off this kind of referred pain to the orbital region. We see it so much in clinical that if the damage is on one side, usually, I mean, the symptoms are unilateral, as we know. For instance, in migraine, sometimes it's one side and then the other. There's kind of this side shift from one crisis to another. And with the cervicogenic headache, it's typically this one-sided, and typically, and it doesn't side shift because there's a correlation between the tissue damage or degeneration with also the headache. It feels so important because we see it so much in clinical practice. Do you think that because the cervicogenic society, I think it's this, I think it's that one that involves thinks that the diagnostic criteria should involve a palpation of the tissues, of the upper cervical tissues, should involve the active and passive movement, also looking for restriction, because they make the correlation between hypomobility and also the cervicogenic headache. So kind of palpation of soft tissues, active, passive movement to have a sense of hypomobilities in the upper cervical spine. Also, I believe one of the criteria was sustained compression in combined movement. So let's say extension, lateral flexion, rotation, and then compression, to see if that triggers neck pain and also kind of triggers the symptoms of the patient, maybe a referred pain. Do you include that in your clinical practice, or there's not so much evidence for those kind of criteria?
No, I do absolutely. That's a good point. I do absolutely include that in my clinical practice. Both classifications do describe and discuss the mechanical precipitation of symptoms during cervical spine testing. The Cervicogenic Headache International Study Group does delve into that a little more. They go into slightly more depth of how you should clinically assess the area to then provoke with provocative maneuvers. But the mechanical precipitation upon suboccipital pressure and cervical range of motion testing is also part of the ICHD3 criteria, actually. And going back to what you were saying of the importance of the side lock pain, I think one thing to consider is also that obviously patient can, in a patient, two types of headache can coexist, so that can sometimes throw us off the road a little bit. And one description that I myself found pretty useful from the International Study Group is that sometimes there can be a bilateral cervicogenic headache, but we should probably not consider it a bilateral cervicogenic headache, but two unilateral cervicogenic headaches. So patients who might have some degeneration or damage or any type of irritation that can then manifest bilaterally in the neck can then have a bilateral manifestation of it. And that might not be always the case. So sometimes they might have it more irritated on the right-hand side and then the left-hand side, and so they might manifest different symptoms. But I think this is also useful for clinical practice because when you see someone with a bilateral cervicogenic, with a bilateral headache, which sounds and looks like a cervicogenic manifestation, then not just because it's a bilateral manifestation, you should think, okay, that's definitely not a cervicogenic headache. It still might be the case, but then you would probably expect precipitative maneuvers applied on the right-hand side of the cervical spine to then cause a unilateral cervicogenic headache, and maybe the other way around on the other side. That's an important point that I forgot to make a moment ago.
That's cool to think about, because also when we think about bilateral, kind of the head, not the head, but the thoughts go more into, you know, tension type headaches, which is also a primary headache, and of course it relates with the cervical spine also, and also it triggers inflammation, and also with the trigeminal nerve involved. But you know, at least my brain goes immediately when there's a bilateral, and there's a kind of a pressure, pain. You know, our clinical reasoning goes immediately to tension type headaches, which we haven't talked about it, but I think it's good to also, in terms of diagnostic criteria, maybe a big difference with this tension type headaches, which are, I feel, more and more uncommon because of computer work and especially mobile phones tapping this type of position. But compared to the cervicogenic headaches, cervicogenic headaches could last hours. You know, they kind of tend to respond well with anti-inflammatory and with manual therapy and with exercise. But tension type headaches, they tend to last they could last weeks. This type of pressure and feeling could last weeks, and usually this cervicogenic headaches, in time-wise, the patients can have, and tell me if you agree with this, they can have symptoms, precipitation of symptoms once a week, 4 or 5 times in a month, but it tends to last for a few hours, because usually the patients, they go out to seek help, you know, either anti-inflammatory or other therapies, because they could be quite limiting. They can really affect really affect normal life, because it's really intense in pain. As for tension type headaches, we see a lot of people that can bear this pressure pain or this tension pain because it's mild, and they can maybe do some stretching, but it's much more mild compared to the cervicogenic headache. It could be quite excruciating pain. Do you agree with what I've been saying so far?
I generally see patients, to be honest, whose cervicogenic headache symptoms last for longer than a few hours, maybe even a few days. But yeah, generally, in regards to the intensity of the symptoms, I definitely agree with you. A person with intense cervicogenic headache sometimes just cannot function.
Yeah.
Person with tension type headache, instead, not everyone, obviously, not every single episode, but they can bear with the pain for a while, still function, not seek any intervention for that right away, and then just do it when the symptoms start to increase. One thing that, from a diagnostic perspective, I think is also important to discuss is that, you know, somewhere between 70 and 90% of patients with any type of headache then go and develop some neck symptoms. So again, whenever you see a patient, you know, neck pain and headache are pretty, not always, but very commonly correlated, and that's where the difficulty in trying to understand, okay, is the neck pain the source of the symptoms, or is the neck pain a causation caused by the symptoms of the headache? And so that's an important thing. So a lot of people with tension type headache then go and develop neck pain because of TMJ restrictions, myofascial pain along the TMJ area and the anterior cervical structures. So that's also an important thing to consider when you assess a patient.
Yeah, and also the key role of this we didn't give a name to it, but this trigeminal cervical complex, this kind of overlapping afferent stimulation between cervical spine structures and trigeminal, coming from the ophthalmic branch. So they really overlaps there, and the pars caudalis, as you said, and of course the trigeminal is also responsible for proprioception of the face and cervical spine, again with cervical plexus, and again that overlaps. I think it could, and also this connective tissue that involves the brainstem and the brain and all of that, this dura, meningeal dura, all this connective tissue, also innervated by the trigeminal nerve, mainly from this ophthalmic branch. And there's also this myodural bridges of the suboccipital muscles between the duromeningeal. All of this kind of involves the trigeminal over and over and over, the trigeminal nerve. That has a very clear anatomic and physiological relation with this upper cervical spine, which makes sense because all the movements from the jaw and sensations from the face also have to kind of include the neck position and also the neck proprioception, and so it makes sense. And so you did this great paper with the I'm going to read it again. And also, by the way, there's the references of your paper and some other papers that you mentioned in your paper are available on when we upload the video on YouTube and social media. So the effectiveness of manual and exercise therapy on headache intensity and frequency among patients with cervicogenic headache, a systematic review and meta-analysis. So I know there's November 2022. There's a few systematic reviews. There's a few debates. I also remember this PhD guy, Australian. I believe his name is Dean. Oh no, I forgot the name of the gentleman. He's a PhD and is a professor, Dean Dartson or something like this. I'm not sure. And he's from Australia. And it's funny because he professes, he's a professor, and he professes that the trigeminal cervical complex has nothing to do with the cervicogenic headache, or the trigeminal has nothing to do with cervical. So it's I've been wanting him to come on the show for like, not on the show, on the podcast, for like more than a year, but he's a very busy man, and I would love to have a sense of what exactly he's referring, because his whole PhD was in relation to manual therapy and cervicogenic headache. But anyways, if I do get I got in contact with his secretary a few times, but it never happened. But if I do get in contact with him, I'll let you know for sure.
Yeah, sounds really interesting.
Yeah, it's cool how this, there's always this debate of this continuously questioning of the things that we think we know, and it's also part of scientific process.
Really, to level.
So what is the difference between this systematic review and meta-analysis? What do you guys find out, or was mainly the differences? Because we know about meta-analysis and systematic reviews and trials in general. We know that there's a risk of bias. We know there's a high or low risk of bias. We know that sometimes the papers include short-term and long-term results. Sometimes the papers don't include other modalities and other therapies. So we can't solely rely on on one paper and all of this. So what did you guys find out, and what is the main differences of this paper?
Yeah, so the reason why we conducted this review and meta-analysis, because the main clinical guideline that we came across, which is the one by Cote et al. Published in 2019, did give some very specific recommendations on what type of manual therapies to use and whether or not to use exercise therapy as well. And they found similar evidence in the end to what we found. So mainly favoring spinal manipulations and mobilization as primary interventions for cervicogenic headache. But they did underline that there was considerable lack of evidence for randomized controlled trials which use sham interventions as comparators. And as we know, obviously, that's fundamental. It's fundamental to analyze these trials to know whether there is a real effect to know, or at least to have a really good estimate on whether to know that whether there is a real effect of manual therapy or whatever intervention they're considering, or whether the placebo effect had a huge role. So we said, okay, let's start from scratch and start this review where we compare any single type of intervention that a manual therapist or a physical therapist or an osteopath or a chiropractor might use in their clinical practice, and let's try to compare them to anything we come across, basically, including sham controlled interventions, which were probably the main focus. But we did not just include sham controls. We also included any other type of control, whether it was surgery, whether it was no treatment control, sham controls, other types of manual therapy, exercise therapy, whatever would come in the articles. So that was, our search was not limited by comparators at all. It was indeed limited by the manual therapies used and the types of exercise therapy we use. So we just included manual and exercise therapies. But again, we tried to be very inclusive just to have a really good outlook on anything that we could find in the evidence. And I think the difference between our review and reviews that were published before is that then for the meta-analysis and for the qualitative analysis as well, the way we describe it throughout the article, not just the quantitative analysis, we try to have very specific divisions on what we compared. So first of all, our risk of bias analysis, our risk of bias assessment was very strict. So using the Cochrane tool, any article that had even one single unsure or high risk of bias item was classified as unsure or high risk of bias. And that's what, because we see it a lot in literature that most authors use kind of a threshold on the risk of bias scale. For example, the group is a risk of a number out of 10, and they can say, okay, if it's higher than if the score of the scale is higher than 7 out of 10, then it's low risk of bias. But it's actually not true. That is not recommended by the authors of the tool itself. So they do recommend that even if just one single high risk of bias item has a high risk of bias, then the study should be considered with a high risk of bias. And that's what we did. Plus, we also tried to categorize in the meta-analysis the comparators that the studies used. So we did compare studies which, I'll try to make it as simple as possible because I use the word comparison and compare a lot of times. So we did compare trials using sham controls only among themselves, and trials using no intervention among themselves, but we didn't compare the two. So in a meta-analysis, we didn't have one trial, two trials, for example, both using spinal manipulation, and one with sham comparator and one with another comparator. They were not included in the same meta-analysis, whilst other reviews before us and meta-analysis did. But that doesn't really tell you much at the end of the day, because you're comparing different things. You're comparing pairs and efforts. So then you kind of not know the difference. So and I think that the fact that we did that really gave us a clear answer on whether those type of manual therapies were better than sham controls. And that's for the general meta-analysis. And then we also decided, because of the quality of the grade assessment, which was either low or very low for all these analyses, we decided to also take a further step and do a sensitivity analysis. So we only included low risk of bias trials. The fact is that among the articles that we included in the meta-analysis, we only had 2 low risk of bias trials. So that's what we had to use for the sensitivity analysis, which is not that much, obviously. It's just 2 studies among the 20 that we included initially. But at the end of the day, that is also actually suggested that that is what is recommended universally. If you have even one only good low risk of bias trial, do a meta-analysis on that and use that as your main evidence, rather than putting together a lot of lower and unsure risk of bias, higher and unsure risk of bias trials. And that's what we did. We luckily had 2 studies by a similar study group led by Haas, made in 2010 and 2018. And they were really high quality and low risk of bias trials. They included quite a few patients, and that's what we work with for the sensitivity analysis. So our main evidence actually comes from only 2 trials but they were the best evidence we had available. So that's what they had to do, and that's where the evidence comes from.
Very cool, very cool. And can you summarize the conclusions of the?
Yeah. So the conclusion of the sensitivity analysis only regards spinal manipulation, and is that there is moderate quality of evidence saying that spinal manipulation has a small to moderate effect, basically, for most of the outcomes that we considered, which are headache intensity, headache frequency, disability, and headache duration at short and long term. So that's the main conclusion coming out of the meta-analysis. Coming out of the general review, we also know that spinal mobilization has pretty good level evidence to back up the use of mobilization in this for this issue for cervicogenic headache. We also know that there is good but still lower quality evidence for other types of manual therapy interventions, mainly trigger point intervention, dry needling, kinesiotaping, which, you know, it's a bit between, it's not entirely a manual therapy intervention, but we included it in the group. And at the end, on the other hand, we know that there is not a lot of evidence at the moment for the use of exercise therapy, meaning that not meaning that there is evidence that does not support its use, but the evidence we have available is not that high quality. So we do need a lot more evidence to make any statements in regards to exercise intervention, exercise therapy interventions. The main types of exercise therapy interventions were low load endurance exercises, which again, I do actually use in my clinical practice, because I always like to give the patient an active role in their rehabilitation and not just be dependent on the manipulations and mobilizations, although they obviously have higher evidence, so they're the core part of what we do together. But then depending on my general functional assessment of the patient, then I pretty much always include also some exercise-based interventions.
Yeah, and that's pretty cool. And of course, yeah, when we think about these patients, also, how do they respond in acute phases or in the recovery phase? So, I would expect a patient on an acute phase. Exercise therapy would kind of trigger a little bit more inflammation and irritation on the tissues, but it's cool to see that. As yeah, I left this. I left this for the end. I'm just a self-report and a case study, which is with myself. I do fit into the typical patient where I had a cervical trauma, upper cervical trauma, doing some silly things, and then I developed over the years. I developed something that we know as cervicogenic headache with the typical symptoms, and I do remember. One time I was up in the north of Portugal with a study group. We were a bunch of friends, but we were part of this study group, and basically we're just studying for preparation for something with the German Osteopathic Council. Actually, one of our colleagues. This was more than 10 years ago, and then. It was like almost 15 years ago, gosh. And then anyways, I remember I was always carrying this anti-inflammatory pills with me, always, everywhere if I would go for a trip or something like this, because they were lifesavers. Because when the cervicogenic headache hit me, gosh, I couldn't function. It was really, really bad. But as we're arriving to this city, which was like a 400-500 kilometer trip, I remembered, oh shoot, I forgot my pills, and the house was in the middle of nowhere. There was no pharmacies, and I was the peak of winter, -4 degrees, and it was crazy. And luckily enough, I had a cervicogenic headache attack by after dinner, and I just had to recur to osteopathy. They were all osteopaths. One of them quite actually already with a good solid practice. And I said, listen, you have to help me, because this is gonna. I'm not gonna be able to sleep. This is really gonna affect me throughout the day. So you really have to help me. And the guy was kind of a bit scared. Not how would I say? Maybe scared is not a good word, but a bit fearful of. you know, I don't know what's happening with your cervical spine. I don't want to manipulate like that. Blah, 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 blah. I said, please. Anyways, he did the manipulation on the cervical spine, and I should say, after maybe half an hour, 45 minutes, all these endorphins and opioids, they start to flood. So the descendant paths of pain really started to kick in. But not only that, so the intensity of the pain really diminished, and I had this flux of endorphins and opioids, so kind of this high. I was on this high of not experiencing pain, but also some sort of happiness just from the manipulation and this flood of opioids and stuff. And I mean, endogenous opioids. I wasn't smoking any drugs, but but what was most amazing, and that's what started my interest in this sort of subjects, was most amazing was just the intensity and the frequency of the headaches really diminished. Meaning, I think the next episode of cervicogenic headache after this one that I described was, I think, 6 months after. And with the anti-inflammatory pills, I was having a cervicogenic headache attack crisis maybe once a week. And after this manipulation, they started being much more spread apart every 6 months. Of course, then I had a relapse, but it doesn't matter. What matters is one treatment, one manipulation. In my case, in my particular case, I'm not saying every patient is going to be like that. You could really see this diminution of intensity and also the frequency of with this spinal manipulation, and so it's good to see there's solid evidence for this intervention. I would say we need a good diagnostic criteria, because people with the migraines probably are not going to benefit so much with this because it's a whole different ball game in terms of physiopathology. But also coming back for this exercise therapy, it's like I don't think I would on the acute phase, I don't think my neck would be, because I tried a bunch of things, stretching, active movements, but on the acute phase with a lot of inflammation, as less movement possible on my cervical spine. Thank you very much, because I wouldn't tolerate. And on a recovery phase, I still do. This has been 15 years now, and I still have to be somewhat not careful, but I have to sleep in the same position all the time. I always have to sleep to my right side. If I sleep to my left side with my neck a bit stretched, that could flare up a headache. So, but I still do a lot of sports and a lot of activities, and I do a lot of neck exercises also, but it has to be on the recovery phase, because on the acute phase, my cervical spine does not tolerate any exercise. So it's actually nice to experience some of that as a patient as well.
Yeah, no, I see. Indeed, I don't, when it's a post-traumatic headache, then things can change a little bit, as we know, because the trauma itself, whether it was I'm not sure about your case, whether it was a car accident or other type of traumas or a fall or anything, then can lead to a slightly different, to a similar diagnosis, but to a slightly different experience of the symptoms, experiencing of the symptoms. But as we know, every headache is slightly different in how the person experiences it. I found that instead, sometimes, like very in opposition to what you were just saying, sometimes with some people with high pain intensity at the onset of their symptoms, they just cannot get into a comfortable position with the manipulation. So actually, before getting into a lot of manual therapy, I just have them doing some gentle nudging of their gentle nodding motions. And for example, I just reproduced the craniocervical flexion test. And that doesn't seem to do exactly just gentle nodding to actually both to recruit deep neck flexors, but mainly in the acute phase, just to give a little bit of active mobility to the suboccipital area. And that actually usually tends to start mobilizing things a little bit, getting them to be less anxious, and then we can get into some more intense, if we want, manual therapy afterwards. But again, it's different for different people.
Yeah.
It's very is very specific experience to each and every one of us. So definitely we have to find different strategies for different people that come into our clinics, really. But yeah, it's really interesting to know your experience, and I can say, luckily, I've never experienced anything similar in my life. I became interested in this field actually because I didn't know anything about it when I was studying. It was not something that I was taught in my first degree, which was physiotherapy here in Italy at the University of Florence. It was something that I knew was just a small part of my curriculum at the University College of Osteopathy in London. And so I said, okay, if I want to, that's something that a lot of patients come through our doors with. We need to know, at least not to be the best in treating it necessarily if someone is not interested in that type of pathology, but at least to know, to recognize, okay, is that something I can help with? Is that something I just need to refer away? And so that's why I studied it. And then I had actually a few patients, relatives, and friends that I see very frequently, and they do experience these type of symptoms very frequently. My girlfriend as well. And so I can really follow them up continuously because I see them every week, almost every day, most of these people. So I know how they're doing. And I saw that, even if I'm pretty much sure of their diagnosis and they really don't show any other symptoms of migraines, tension type headache, and any other primary or secondary headaches, then I can see that their experience of it is very different, and our interventions are very different for each and every one of them.
Yeah, it's amazing because we could really help in some of these conditions. Manual therapy can really help in some of these conditions, and sadly, many, I would say the majority of courses are almost focused. There's a huge portion on this musculoskeletal, but they kind of left out some of the cranial kind of. There's actually an Italian study, I believe, from 2020. Not sure, and it was kind of a how do you say, a questionnaire on osteopathic community and how whether they feel comfortable in Italy in assessing cranial nerves and understanding cranial nerve pathology and physiology and also headaches and stuff like that. And the majority of them felt that they were not comfortable because it was not part of the curriculum in academic undergraduate studies, and so it was kind of a gray zone in terms of knowledge, understanding, and also intervention. So the study concluded actually they needed more, at least in Italy, but I would say I've been teaching in Portugal for quite a while. And of course, we know that 4 years are not enough to teach everything, but there's like a gap between all the other musculoskeletal conditions concerning limbs and thorax and all of that. And one of the major conditions that people that patients look in to osteopaths or chiropractors is actually some sort of a headache. And if the right or a good anamnesis is not present, then some important signs can escape. I'm not even talking about red flags. I'm talking about some important signs can be missed, and we can actually help in many of these conditions, including cervicogenic headache. Thank you so much, Pietro. It was a nice talk. It's nice to see this liveness of young academic interest, and it was really nice talking to you and to have this feeling if there's a solid. First of all, congrats for your studies, for your paper. And it really feels that you guys are really know what to do, and we're very specific in what we're looking for and your criteria, and also to contribute to this more solid certainty of this certainty as much as we can have of this benefits of manual therapy and for spinal manipulation on the cervicogenic headache. Thank you so much, Pietro. It was
thank you very much, Bruno. Thanks for inviting me again. It was really nice chat, and thanks for running the podcast. It's always really nice to see different professionals just sharing their opinions on something they hopefully know about. So yeah, thanks again. Thanks for doing
great.
that.
All right, thank you, and I see you soon.
Cheers.
Cheers. Ok, muito obrigado por terem ficado aí. Portanto, vamos acabar com o podcast e vamos terminar por hoje. No próximo podcast vamos ter a relação de intervenção osteopática em trauma craniano, na relação com a doença mental. Vamos ter uma série de podcasts que já tenho falado sobre isso, interessantes para nos próximos podcasts. Obrigado, desejo boas festas, bom Natal, bom Ano Novo, e até breve.